Yeah, it's like now sometimes.
Right, yeah.
Yeah,
When we were there.
yeah, so it's,
I'm like,
yeah.
exactly.
That's the.
Right. Well, I love Richmond.
Yeah. Oh, maybe I forget.
Yep.
What do you have?
Can everyone hear us?
My oldest friend.
It is
And
slowly.
Completely
Yeah.
flawed and miserable, so.
Thanks for asking.
Things that are nice. It's crazy. I'm curious.
We have a type of thing.
What you do, whatever nice to see. Yeah. Christina, this is Dr. Barry Chang, who's the new dental dentist.
Hey, you're filling big shoes, but I have a lot of confidence.
Okay. Hopefully.
Nice to
We'll
meet you.
work hard on that.
I was just asking if anybody knew, but my dentist is in a lead position at Delta Dental, so I was just asking him last Thursday. You guys heard anything?
Oh,
He said, I didn't even know Sarah left.
Who's your dentist?
Bulldog.
Oh, yeah.
Yeah, we almost invariably talk a little bit of Medicaid shop while I'm waiting for the Novocaine or something to hit, between the x-rays and the technician.
Good for you. You're not just laying there in fear.
No, I'm an avid consumer of dental services, and I have to go fearless.
Gotcha.
Had a root canal once that they couldn't numb me for.
Oh,
They
God.
had to drill holes in my jaw twice to try it. And it was Doug Katz. He's an endodontist who I've known for years. He's a good friend too.
Yeah. Is he still a good friend after that?
He is, yeah. And after the second attempt, he said he thought he might have to send me to like a friend colleague in Boston.
Mhm.
And I said, who's more up to speed than you are? Like, who's more likely to get this done? I said, let's just do it.
Oh my God.
And we did.
You're on another level.
That's so outrageous.
Yeah.
Yeah, I play with 1,200-pound animals for fun.
I was already not going to cross you, and now.
Oh, good, no.
Yeah, so-
No, Olivia, no. The benefit is in having me on your team.
Right, exactly.
That's
Where we want you. Can folks hear us online okay? Okay, awesome. And I know Lisa Britt's on virtually today. I think, are we
Morning.
expecting, good morning. I think we're expecting Kelly here.
No, she will.
Oh,
Her
she's-
alternate will be.
Oh, that's right. Thank
She's
you.
on vacation.
Okay. I am gonna give it just 1 or 2 more minutes, and then we'll get started. Thanks,
Okay,
everyone.
just let me know.
Hey, Don. This is Dr. Chang. Yes, yeah.
I probably have it online, but I'll take that hard copy just in case. Thanks so much. Yep.
Kristen, let me know when we have a quorum.
Maybe when I can't get on the internet, things may not totally. Oh, look at us in red. I was going to mention this one of these.
Oh, that's smart. Yeah, it's not that many foot wells.
Right.
Yeah. And then you don't have to get some other like distinguished picture. Like I was saying, very tall.
I used to be able to do that.
Yeah.
And then I used to.
member or alternate.
Good. Lisa, Britt, we have a quorum, so whenever you want to kick off.
Excellent. Good morning, everybody. So let's kick off June's MAC meeting. I heard you doing a couple of introductions, Olivia. Do you want to refresh for the whole group?
Yeah, we can do a round of intros in the room. I'm Olivia May. I'm the Director of Medicaid Enterprise Development. And with me today is Dr. Barry Chang, who is our new dental director. Those of you remember Dr. Finney, who retired a few months ago, so he'll be stepping into that role. We're very excited to have him. And he'll be joining these going forward for all of our adult dental and other dental program updates. And I'll pass it to Don. We have Don Tierney, our policy administrators in the room, David Chorney, Deputy Medicaid Director, Kristen Finnefrock, our administrative assistant, Carrie Cola, consultant to the department, Christina Ickes. Can you remind me your title? Jack of all trades.
Yeah, long-term care administrator.
Long-term care administrator.
Yeah.
And Dee, do you want to introduce yourself quickly?
Yep, Dea Janae, D is fine. I'm the communications director at Disability Rights Center in New Hampshire.
And that covers us in here.
Very good. Thank you. Welcome, Dr. Chang.
Thank you.
So we have no consent items this morning, so we can breeze right through that. We already picked up 5 minutes. So let's jump. We do have 2 months worth of minutes to review and approve.
So we are in a minutes backlog at the department. We are going to send out both copies of the minutes for review on the July agenda. They are ready to distribute. And sorry for the delay on those, but I think we'll be able to close up the fiscal year with all of our minutes.
Okay, so if I heard you correct, in July we'll do April, May, and June.
Yes.
Yes.
Okay. For a second, July felt really far in the future until I, realized, oh yes, this is the June meeting. I just said that, but it still seemed really far away. Okay. Well, we just picked up another 10 minutes. So we do have several items that the department is tracking for future meetings, including a discussion on the MEA, Lisa DiMartino's request for presentation on workforce, sort of status of the workforce for direct care, and some provider relations training. Do other members of the committee have agenda items that they would like to add for future meetings?
I'll just provide a quick update that we anticipate doing an MEA presentation in August's MAC in partnership with LTSS. And then for provider relations and workforce direct support, we've given some response on both of these. I think we're looking for any more guidance on if there is a need for a presentation, what is more info on the topic and what folks would want covered. So we'll just keep it on here, but if we don't kind of hear back on that, we'll take it off the list eventually.
Yeah, and I think that was something that Kelly had suggested based on a conversation that she'd been having with some folks who were newer to billing in, I think, the long-term care, I think even DD space. But I'll make a note to reconnect with Kelly just so that we make sure that it's meaningful. And
Okay.
Are there other suggestions from committee members before we move on? All right, hearing none, let's turn it over to Olivia so that we can touch base about the Beneficiary Advisory Committee subcommittee that has been trying to work on the structure and the bylaws, et cetera, for BAC, which will start next month, right?
Yeah, so I'd actually like to, if it's okay with you, Lisa, but kind of combine the next 2 items, the BAC,
Sure.
MAC transition, and just kind of give an integrated update on both. So
That
as
sounds
folks, great, thank you so much. As folks probably recall, Now about a year ago, the federal government released new rules on states' obligations around Medicaid advisory committees and introducing the Beneficiary Advisory Council. So since the release of those rules, the department's been working with subcommittees from this group on how to prepare for those new requirements. Thank you to everyone who's been along for the ride on this, Dee, here listed and others. So I'm going to give a couple updates on the MAC transition and bylaws and then move into DAC. For MAC, we had to make a couple changes sort of directly in response to the federal regulations. One is to have a seat representing MCOs on the Medicaid Advisory Committee. So we're going to just have one seat added that will be occupied by one MCO on an annual basis and rotate between the three. So I will be reaching out to the MCOs so that we can fill that seat following our July meeting. In our July meeting, we will want to vote on the bylaws, which I think, Kristen, are nearly ready to be shared in draft form. We just wanted the committee to review them one more time. So once we get the draft bylaws out, you'll see a few things that are proposed to change that are pretty meaningful. So one is the cadence of the meetings. After discussion with the Beneficiary Advisory Council Subcommittee and the MAC Subcommittee, the proposal is to move to a quarterly cadence where the MAC meets and the BAC meet quarterly. The BAC would meet in advance of the MAC meeting, which would allow the input and feedback from the BAC to inform the agenda of the MAC. So that, obviously is a change from how we operate today. I wanted to just kind of verbally highlight it. Again, you'll review the bylaws and we'll vote on them in July, but that is what both subcommittees have kind of proposed we explore for cadence. The other big change is terms. The federal requirement is now that we have to have terms for members and they cannot serve consecutive terms. We're handling this in two phases. One is everyone who's in the committee today, and then everyone who joins the committee in the future. For everyone in the committee today, we've been reaching out to you to figure out how much longer you'd like to serve in your current term. So those terms are going to range from 1 year based on your feedback to 4 years. And then when you conclude that term, a new term will start for that seat, which will be, we're proposing a 4-year term. So again, once everyone phases out of their current seat, 4-year terms for all seats, except for the MCO seat, which is 1, and you can't serve consecutive terms. This does not mean anything for the chair and vice chair, which is separate, and will have its own process similar to how we operate it today. So let me just pause there. I know it's a lot of administrative changes, and we'll work on having sort of a cover summary when we set up the bylaws draft itself, which we'll vote on in July, but just wanted to raise it today for any initial questions or feedback, and I'll just pause there. Marissa, go ahead.
Hi. So does this apply to the agency seats as well? And what do we do if we only have one person at the agency who can be in that role?
That's a great question. It does not change the agency or what we call the institutional seats. So we're not proposing any changes at this time to what are the institutional seats of the MAC.
Okay. Thank you.
But it's a great point that if there is only one person to fill that, how we're going to manage that. We should probably talk separately about how to address that, because we do kind of have this federal mandate to not do consecutive terms. So we'll have to connect and problem solve that, I think.
Thank you.
Thank you. Joan? You're on mute, sorry.
Yes, I just coming on, thanks. So I'm just interested in your sustainability protocols. Obviously, I'm thinking term limits and term times are related to sustainability and keeping fresh and new and all of that. But piggybacking off of Marissa's issue or question was, how are you planning to support those that need to transition out and bring others in? Do you have a plan for that?
Olivia, do you want me to share?
Yeah,
some
go
of the
for it, Brooke.
conversations? Yeah, so that's a really great question, Joan. I mean, one of the things we talked about in the subcommittee was, how you preserve the institutional knowledge and experience from members who've been on for a long time, with the clearly stated desire from the feds to have new perspectives on the committee. And so I think what the department had suggested and the subcommittee was supportive of was, having staggered terms so that everybody doesn't expire at the same time. The fact that just because an individual is no longer, in particular, this will be the most impactful on individual seats rather than institutional seats, right? Because an institution can have in many cases, can have a different person in that chair, whereas a person who is an individual, they're going to need to rotate off for a period of time. The fact that an individual can come back as a member of the public and still have their voice heard and still have conversations and have, be able to absorb the information being shared at the meeting was an important component of this. There were conversations, and I think, Olivia, correct me if I'm wrong, we're still trying to flesh out the fact that our chair and vice chair is there, in many boards that a number of us on the subcommittee have been on, those individuals have an ex officio, often ex officio with a vote, role after their chairmanship to ensure that their leadership experience is still available as a resource to the incoming leadership as well as the committee more broadly. So talk about how do we incorporate that. So sustainability, continued knowledge, as well as honoring that intent for fresh perspective was all top of mind for the subcommittee as we're working through all of these pieces. We also talked a lot about, what goes in the bylaws versus what goes in sort of working documents and working papers to help make sure that the bylaws are as narrowly tailored as is appropriate, but don't get super bogged down into process and procedures, but recognizing the value that many of those processes and procedures have to all of the members of the committee, as well as members of the public who want to take a look at those. And so to have those available as well. So really figure out where do all of these important pieces of information fit.
Thank you.
I hope that was helpful, because Joan, it's such a great question and something we spent a lot, probably a lot, maybe too much time, Olivia, but we spent a lot of time because it is really important and want to make sure that we're doing this mindfully while making sure we comply with the changes required by the feds.
Right. Thank you. It is this similar for those of us in organizations itself. Sustainability is always a challenge.
Absolutely. And I just want to highlight what Brooke said about participating as a member of the public. All of our meetings in MAC are open to anyone who wishes to join, and we would definitely encourage anyone who wants to continue participating in that capacity to do so. I see a couple other people coming on camera. Does anyone else want to weigh in with comments or questions? A couple, kind of less, less juicy updates, I guess, on the MAC and BACs that will be also required to post an annual report on the activities of both. So the first one of those will be next summer. We'll also be posting publicly this is actually connected to what you were saying, Joan, the department's recruitment process and strategy, which I think, given the term requirements, will become very important for how we proactively identify folks who may be interested in participating. So that will be something the department has to start doing. On the BAC, we have received a lot of applications, which is very exciting. We definitely have enough applications to start a group. What the department may do just
We lost you.
can you hear us now?
You're back.
Okay, sorry about that. For the BAC, because we still would like to have a little more balance with people who are themselves Medicaid recipients versus parents or caregivers. I think we will likely start with a group of about 8 and reserve, a couple of seats if we continue on and identify other participants who kind of meet that experience background. We also have the requirement of overlap with the BAC or with the MAC, so I think having more BAC members will help us accomplish that. I think those are most of the major changes under consideration, and that will be reflected in the draft bylaws for both BAC and MAC. So I'll pause one more time if anyone has questions or comments.
My question, Olivia, is when might we see the draft of the bylaws?
So I think the BAC bylaws are ready to distribute. The MAC bylaws, I think we need one more meeting to tie it up. So we'll prioritize having that this week so that we can exit that meeting hitting send on the draft.
Great.
But we have one. I think there's just a couple lingering edits we just want to make sure the subcommittee is comfortable with. Doris, I see your hand is raised. You're on mute.
You're muted.
All right. I would also recommend that rather than distribute the BAC now, even though it's like the penultimate draft, that we have one more round of looking at that when the MAC draft is done too, so that we have consistency between the documents. Our last conversation, we made a couple of references to the BAC document, but we didn't have the time to look at them concurrently. So I wouldn't want to send that out in advance and then say, oh, well, we want to change these things to make sure that we've got synergy between the two documents. Or
That's
a single
great point.
Yeah.
Maybe what we'll do is try to have one last joint meeting with both the MAC and the BAC subcommittees so that both subcommittees have a chance to look at the two together. If that works for you, Doris and Dee and Lisa Britt, we can go ahead and just do that.
Yeah. So maybe aim for the end of June or so.
Yeah, I mean, I'd like to get them out in the next 2 weeks just so that folks have time to look at them before the July meeting.
That sounds great.
Okay, anything else?
Okay. I know there was a bit of a question mark about whether we would do a legislative update. It doesn't appear that Rob has joined. Should we just leapfrog over that, or is he expected to come in a bit?
I know Rob is in something now. Let me check in with him. Let's continue on the agenda and then we might circle back.
Okay. All right. Well, Dave, let's talk about enrollment and eligibility.
Great. Let me share my screen just 1 second. So this is the enrollment and eligibility report for May. So as of the first of the month, this is the enrollment trends for the standard and granted advantage population. So we're down a little bit from the prior month, just over 183,000. Granted advantage is still about 7,300 higher than it was prior to the pandemic. And standards just right around where it was after the start of the pandemic. And this is a modification of a slide we previously presented. So this is tracking all of the various eligibility groups. And we used to show this back from November of 23, which was the low point of enrollment from the unwind, but now we're just tracking it just to see the change in the prior 12 months. So you can see the adult group, which is Medicaid expansion, is kind of like a roller coaster. It's the brown line here, but we attribute a lot of this. So the middle of this graph is December, January, which is open enrollment on the exchange. And so we generally see Granite Advantage spike up during open enrollment because the federal marketplace will transfer cases where they appear to be Medicaid eligible. And so we see an uptick there. We're still seeing some increases in the child eligibility groups. And this is expected just from the 12 months continuous coverage for children that went into effect of January of 24. This is a same look, just a little bit different, and this also goes back to the low point in November of 23. So we can see it over about a year and a half now. This is the updated dashboard for the adults that had redeterminations in May. So there were just under 11,000 people due for redetermination in May. 10% closed at 1,200. 9,100 completed their redetermination. A large majority of them were passive. The biggest closure reason was failed to read, which, just as a reminder for everyone, is that occurs when someone doesn't go passive. They get the renewal form, it's sent out, and then if it's not returned or the verifications are not returned, they show up as failed to read. The second biggest closure reason was income, with 212 individuals for adults. And then for kids, there were 4,600 kids that were due for redetermination in May. 536 closed, almost 3,800 completed the redetermination. And similar to the adult population, the majority of the closures were failed to read, 389, and then 84 due to household income. And this is for the waiver population. So there were 875 individuals that were enrolled in a waiver eligibility category that had a redetermination in May. Only 9 closed. 772 completed their financial redetermination. And there were no failed to readies in the closure populations. It was income driven mostly. And this is a drill down into the waiver population for CFI. So there are 246 CFI individuals up for redetermination in May, only 3 closures, and 218 completed their redetermination. And then this is the further drill down into the nursing facility coverage. So there are 237 due for redetermination in May, 1 closure, and then 195 completed their redetermination. This is just a CMS reporting slide of the closure reasons that we submit to CMS. See, the retained rate was almost 88%, which is consistent with what we've seen in prior months. And then the closures by reason, with income at 16.7% and failed to read at 62.7%. And this is just our ex parte slide. I don't yet have July, but when we have it, we can certainly update this slide, share it to the group. But with the E14s expiring at the end of this month, we expect that the ex parte rate for July will probably be closer to the numbers we see on the far left-hand side from 2023. And next up is an update on our communication campaign. So I'll kick it over to Vern for this.
Hello, everybody. Just an update for the outbound communication for those that have failed to do their redetermination. We did see an increase in the number of calls to be made by the MCOs last month. They went from 806 up to 949. Of those, 300 were reached for a reached rate of about 32%. That actually was a little lower than the month before. For the MCOs where they were able to engage, 28% had already completed their redetermination. That was up a little bit. We did see an increase in those that were aware and working on their redetermination. That actually went from 36 to 46%. So of those that we reached, 10% additional knew that they needed to do it, just hadn't completed it yet. We also, in looking at those that were doing their redetermination found to be ineligible, we've seen that number stay stable between 2 to 3% of those who've done their redetermination. We did see 35 individuals that had actually new insurance, and of those, 21 were children. We'll go ahead and go to the next slide. For the Medicaid unit, making the calls out on those who had had a message left by the managed care organizations. Of the individuals that we reached, we were looking at about a 33% reached rate. 13 of the individuals that were reached had already completed their redetermination and were now open, an indication that possibly that they acted on their messages from the MCOs. 10 were aware that they needed to do it and were actively working on it. One indicated that they did not need it any longer, but didn't say why. 12 of the individuals that we reached out to from the Medicaid group had new insurance. They were all children. And so it was nice to see that we've had that increase in children that are covered. One of the things that we are going to be incorporated in our outbound calls going forward, preparing for the end of the E14 authorities, is we're going to have an option to warm transfer any individuals that we reach that are not sure if they're going to be eligible to retain their Medicaid to the New Hampshire Navigators, so that they can assist them not only to determine whether or not they might still be eligible for Medicaid, but also if there might be insurance on the marketplace, which they would be able to obtain. Any questions? I saw Joan has her hand up, but it looks like that might have been before I started.
Well, actually, it's two ways.
It's twofold? Okay.
Twofold, and it might be simple for all of you, but for me, it's something that I'm learning. How often does a person need to redetermine their status? And the other one is, are you also using text to reach out to your people?
Redeterminations happen on an annual basis.
Annual. Okay, thank you very much.
There is a provision in the congressional budget reconciliation language that would change expansion to every 6 months. But that has to get passed through Congress. And then we do send text reminders too, along with emails and other
Thank you.
notifications.
All right, thank you.
Thanks, Brian.
Okay. Shall we move on?
So Lisa, I just wanted to let you know that Rob did come to the room. So
Okay.
He's available for the legislative updates.
All right, then let's go back to the legislative update.
Well, sorry guys, I didn't realize I was such high in demand. You guys moved way too fast with the agenda. I think I have more time. So we are towards the tail end of the legislative session. At this point in time, the Senate just passed their version of HBs 1 and 2. I'm going to focus on that for the purposes of this legislative update, since it's been relatively quiet on the other bills, the non-budget related bills. between the last MAC meeting and this one. Just from procedural perspectives, the committees of conference will start forming towards the mid to later part of this week. Any bills that were not passed as exactly as the previous body passed them. So, for example, the House passed a bill and the Senate amended it. The House either has to concur with the Senate's version of it or not concur and request a committee of conference or not request a committee of conference. If they request a committee of conference, then they'll speak about it and decide whether or not they want to come to a resolution on it. So that's what we're looking for. HB2 will almost certainly go to HB 1 and 2, I should say, will almost certainly go to a committee of conference, but we won't know that toward the end of the week, and they'll begin either later this week or early next week. So I'm just going to highlight some of the Medicaid provisions, or actually the Medicaid provisions I could find in both the House version of HB2 and the Senate version of HB2. I'll make a note where there is concurrence in both bodies or where there is differences. So without further ado, I'll start off. So the Senate, in their version of HB2, passed a provision that created an advisory council on the system of care for healthy aging in New Hampshire. And I believe this is, I didn't have a chance to compare this to another bill, but I believe this was language that was in another bill that had been ITL'd at the House committee level. But I have to go through and do a deeper dive on that. The House and Senate both passed a provision which would suspend graduate medical education payments. I believe this is a routine boilerplate provision in HB2. Similarly, House and Senate both had provision suspending catastrophic aid to hospitals in their version of HB2. The House had a provision related to Medicaid to school supplemental funding, where in order to receive any additional funding or federal funding, it would have to receive approval from the fiscal committee. This was not in the Senate version, so I expect this will be a topic of the committee of conference. The House and Senate both had a provision relative to the way Medicaid care management funding was treated with respect to lapsing funds. The House had a provision suspending congregate housing payments. The Senate, however, had a provision that appropriated $700,000 for congregate housing for the biennium, so $350K per fiscal year. So that's those are in direct opposition to each other. So I expect that'll be a topic of conversation. Both the House and the Senate retained department requested language relative to Medicaid pharmacy, specifically allowing the department to utilize brand names over generics in the event it was achieved a net cost savings. So we were happy about that. The House and the Senate also both incorporated language relative to chief medical officer standing orders for over-the-counter medication as well. Both the House and the Senate had language relative to pharmacy copays of $4. Both the House and the Senate have language relative to one rate filing for managed care organizations per fiscal year. The House and the Senate both had provisions related to premiums for Brandon Advantage for individuals who are 100% or above of the FPL, and for families with children with incomes of 255% or above of the FPL. The differences are the House had just a very general statement about how they were to work. The Senate had more in-depth details about it. So there is some slight differences there that will need to be worked out at the committee conference there. The House had a prohibition on Medicaid paying for circumcision. This was not in the Senate's version of the bill. The Senate had rejected a bill with this language earlier on in the session, so I expect this will be a topic of conversation at a committee conference. Both the House and the Senate had language relative to Medicaid payments for at-home dialysis. Both the House and the Senate had language relative to a report on cost avoidance associated with the adult dental benefit for Medicaid. The House had a provision removing the general fund prohibition for Granite Advantage. This was not in the Senate version of HB2. But the House and the Senate both did change the Granite Advantage funding to include premiums, the newly instituted premiums that I mentioned earlier. The House and the Senate both had language relative to Medicaid to schools termination. If there was any action that went against parental choice or consent. Both the House and the Senate adopted language relative to an outpatient procedure incentive program.
Sorry, there's a hand up, and I'm not sure.
Oh,
if
sure.
it's timely.
Go ahead.
Oh, it can wait until
Go
you're
ahead,
done.
Cheryl.
It's fine.
Oh, okay.
Hi. Yeah, it can wait until Rob's done with his
Okay.
presentation.
Where was that?
Sorry.
That's all right. The House had the provider rate reduction for Medicaid. This was not the Senate version of events. This was a 3% provider rate reduction. The House and the Senate both had provisions related to delaying capitation payment increases or changes, I should say, to fiscal year 2028. And now we get into very exclusive Senate provisions. The Senate had a provision in their HB2 related to letting the E14 authority expire. The Senate also incorporated biomarker testing language into their HB2. This was from a bill that had been introduced earlier in the session. They also included language for Medicaid reimbursement for early childhood mental health.
Can you just back up the biomarker? What is that?
Biomarker has to do with, is it for cancer?
Yeah,
Risk.
it's for certain treatments, I think mostly around cancer, where they'll test certain biomarkers to see likely someone may react to certain cancer treatments. And so we do cover biomarkers currently, but there are a lot of biomarkers out there. Some of them don't really have a lot of clinical utility or value for treatment purposes. So we do an analysis, or Dr. Ballard does an analysis of whether there's clinical utility to the coverage of a certain biomarker test for a specific cancer type.
And what would this bill do?
It would have Medicaid pay for it, I think also private insurance. But it didn't really affect us as much as it did the private insurance.
Thank you.
So the Senate also included the provision about resubmitting the 1115 waiver for community engagement requirements. This is a bill that had been introduced in the Senate and stalled at the House Health and Human Services and Elderly Affairs Committee, where they retained it to work on it. But they included that in the Senate's version of HB2. The Senate also included the language from a bill relative to administrative day rate for postpartum hospital stays. This is a bill we worked with Senator Princess on, and David can explain more about that than I can if you have any questions about it. The Senate also included language to establish a New Hampshire Children's Mental Health Association. The Senate also included language for maternal mental health screening. It included a language for supportive housing services appropriations. It had a provision in there for a $10 million appropriation for room and board for ABD and individuals with disabilities who are residing in community residences. The Senate also had a provision for a committee to study long-term care, managed care. The Senate also included language for an appropriation for hiring a contractor to assist the department with long-term care eligibility determinations. And it also had a provision for case management rate setting. And those are the major Medicaid provisions. This is just a cursory review. I haven't done a line by line, but that's what I was able to find. So with that, I'll take questions.
Carol?
Yes, there was a bill, SB 125, that related to clinical eligibility requirements for nursing home level of care. And it was tabled by the Senate to be incorporated into HB2. I think the original fiscal note just had it down as indeterminate cost, but from what I was told, the department submitted a updated fiscal note during budget discussions that said it was going to cost millions and millions of dollars. Which I'm kind of surprised about. So I was just wondering if we could get a copy of that fiscal note or some explanation as to how that calculation was made, because because of that fiscal note being introduced, the bill was pulled and it's not going to be incorporated into HB2.
What was the bill number?
Senate Bill 125.
Oh, okay. So Brian worked on this one. I'll have to touch base with him about this, but I can do that and get back to you.
Okay, great, thanks. And then I could just, as a different topic, as far as SB 288, my understanding SB 288, it was never killed. It's the same bill. What changed was that originally it was set up for the department to be overseeing this advisory council. I guess the department didn't feel it had the capacity to do that. So it proposed instead to have the Commission on Aging do it. And then that still is pretty precarious in that the Senate, although the House originally cut all the funding for the Commission on Aging, the Senate did put more money back in, but it's like, a little more than half of their original budget. So now they have a new responsibility and less money to do with. But that's what SB 288 is.
Okay. Thank you.
Yep. Mm-hmm.
I was wondering if you could speak to Project Walk. I know House defunded it. Did that get back in on the Senate side at all? And are there plans for those who receive Medicaid to have coverage for Project Walk? The department working on a workaround for that?
So we did ask for a prioritized need in both the House and the Senate phase, and it did not get funded by either the Senate or the House. I think it's my understanding it would still be available for individuals who are under a waiver, but it's not a coverable service from Medicaid. So the individual, I think we're working through a potential transition plan. So someone needs to be eligible under a waiver for that.
Okay. The other question I had was around the Medicaid to school and the parental choice. Is that student, based on an individual student, if there's some sort of a violation determined,
I can read the
theirs
exact
would
language.
be taken away, or would it be taken away from the whole school? Like eligibility to receive the.
I think it's the entire program. So So it says the program shall terminate statewide if the federal government or state adopts any policy contrary to a policy requiring parental control of all medical services provided to children. If a local school district adopts such a contrary policy, the program shall terminate for that school only. So there you go. There's a
For the school.
there's a silver lining there.
But as our program exists today for Medicaid to schools, we don't think we come into conflict. with
No, I
those
don't think
intents
we
of
do
parental
either.
consent.
We've tried to politely explain how this works to them.
Okay.
Does that make sense to you? So like, we don't run the program today without that.
Without parental consent.
Correct.
Yeah, okay. Thank you.
Looks like we have
See another
another question. Yeah.
Sam?
Hi, thank you. Thank you, everyone. My name is Sam Burgess. I'm with New Futures. I had a quick question. I just wanted to circle back quickly to the work requirements provision that's been included and passed through the Senate budget at this point. I know that we have obviously our past version here in the state, which is going to resubmit our 1115 waiver. And at the same time, we have a competing requirement that's been worked into the federal reconciliation bill. So it seems like we're headed towards work requirements on one way or the other, either on the state level or at the federal level. My question is, I just wanted to sort of figure out what if those conversations around outreach and communications to the potentially affected populations under Granted Advantage are happening, or that's something the department is planning to work on, to ensure, because I know that in 2018, 2019, when we first attempted work requirements, that outreach was part of the department's plan. So I just wanted to sort of see what kind of conversations are going on behind the scenes. Thanks.
Thanks, Sam. Yeah, I think a lot of communication is being discussed and would be planned, whether it's the state version of work requirements or the federal version of work requirements. I think we're still trying to figure out, there's the populations that would be covered under the state program versus the federal program don't overlap 100%. I think there's a lot of overlap, but there is some nuance there. And then the timing would be a little different in each. But yeah, I think a robust communication campaign and partnership with stakeholders would certainly be part of that, similar to in 2018. I think in 2018, people from the department were walking around, knocking on doors, and doing everything they could to help people maintain their eligibility.
Thank you.
Great. Anything else on legislative? Okay. Hearing none, should we turn it over to Carolyn for community reentry?
Sure.
Morning, everyone. I'm Carolyn Richards. I'm the waiver administrator for the 1115 demonstration, and this is our first post-award forum for the community reentry portion of the 1115 waiver. I'm very excited about this waiver demonstration. It's a real challenging but exciting task for us, and I'm excited to share our progress so far with you. So please, Kristen, next. Okay. Oh. So community. Oh,
Did you need to?
No. Okay, that's good. Thank you. Community reentry is, like I said, part of the federal initiative focused on improving care transitions for justice-involved individuals. It's part of the 1115 demonstration through CMS. So it's new for everyone, including Department of Corrections, dealing with Medicaid. They've never dealt with Medicaid before. So this is a new initiative for working with them, and it's been great so far. So some of the questions that have, people ask in workshops we've been in are, how does it benefit states? So the goals are to lower recidivism, which in turn lowers healthcare costs for Medicaid. So they coordinate care for individuals that are incarcerated and to help them integrate back into the community where they can be contributing members of society and continue their care after being released from incarceration. So, and it also gives us the opportunity to leverage some federal funds for some of those services that we were not able to take advantage of in the past. So it's a limited time frame that we can use those funds, and it's a limited time frame for the services, but it's a new initiative for us and it's really exciting. So the objectives, as you can see on the right-hand side, are coverage continuity, access to services, reduce morbidity and mortality, and lower the risk of relapse or recidivism. So next slide, please, Kristen. So we included community reentry as part of our application or extension application back in 2022, which community reentry was really, we had just kind of heard about it. And Director Littman had worked with Department of Corrections to kind of we wanted to include that in our application because it was something that we were really interested in doing and working with Department of Corrections on. We did receive approval on July 16th for our 5-year extension of our full 1115 demonstration, which includes the substance use disorder and serious mental illness, as well as a denture piece for nursing facilities. So our implementation began on January 2nd of 2025 in New Hampshire State prison facilities only. So far, that's what we wanted to start small and we didn't want to get too ahead of ourselves. So that's where we've begun with our state-owned facilities. The population that's eligible is Medicaid eligible inmates with behavioral health, substance use, or serious mental illness. Our time frame that we will be covering the limited services is 45 days prior to their anticipated release. The services that are covered are MCO enrollment, care coordination, pre-release visits with community-based providers, which really take place via telehealth because it's very difficult to get. You can't really get inside prisons, but the Department of Corrections has really worked to develop telehealth booths, and to get secure areas is difficult at times too, but they've really overcome some barriers and really started to make that work. So that's been really great. Working with the Department of Corrections care managers, the MCO care coordinators, they're scheduling meetings, pre and post release, peer support, and a 30-day prescription is given to inmates upon release. And that's all covered by the waiver. So that's a really great thing that didn't happen before. The delivery of services happens with the managed care organization providers. The Department of Correction pharmacies are the ones that distribute the medications upon release, and they're the ones that pay for it. Other community-based providers and the Department of Corrections reentry coordinators. So these are just a timeline of things that have happened. Like I said, in September 22, we applied for our waiver. We submitted an addendum. We got a temporary extension, our 1115, and then the extension was approved in July, and we began implementation in January of 2025 in the state prison facilities. This slide tells the key partners that are involved in the service delivery of community reentry, and there's 3 real key providers. The DOC providers are, the case managers were always the providers in the past. They're the ones that always were the helped with every need of the inmate. So they will continue to conduct their planning, but now the state of New Hampshire, or Medicaid and BFA, Bureau of Family Assistance, steps in and helps with their Medicaid eligibility screening, and they work with the DOC case managers to do that screening process, and they support the MCOs with identifying inmates for pre-release appointments and things like that. So The new aspects are really helpful because they will get that application in and it will make them eligible for community reentry. And so that will in turn make them available and eligible for full Medicaid upon release, which was a huge leap for us, and it was really great for the incarcerated individuals. So the pharmacy continues to provide the pre-release meds for the inmates. They also will provide them with a 30-day prescription supply of meds, which previously it was 14 days of prescription meds. Now it's 30. So that's a big deal, and that was a lot of discussion due to sometimes appointments aren't available immediately after release. So giving them that extra few weeks of meds is really important, and that's all medications, not just Sutter SUD related meds. It's every medication they're on, blood pressure, whatever the case may be. So it's really great. And they also can bill Medicaid for pre-release MAT and 30-day supply of release meds, as I said earlier. So the managed care organizations do, as you can see, they're the coordinators of all their care. They create person-centered care plans. They schedule their appointments, and they are the ones to reimburse the community-based providers for any services they deliver. The community-based providers are as you can see, CMHCs, examples of doorways, peer support, and any other private psychiatrists, any private practitioners that the inmate may have a relationship with. The community-based providers do have some, we do have some rules. They have to be enrolled in Medicaid. They have to be able to conduct virtual intake appointments because they're not able to schedule in-person appointments at this time. And they will provide peer support services, virtual or in person. So we, as the state, have decided, as we've been learning through this process, that we meet weekly with the community-based providers. We have what's called office hours. So we have an open forum where we are available. The state is available to community-based providers to answer any questions they have, to kind of give them any updates that we know of. We meet weekly with the Department of Corrections, at least weekly. Managed care organizations, same, at least weekly or bi-weekly, depending on the need. Go over cases, do things. So we're really trying to stay on top of everything that's happening and to avoid any real, issues that would come up. We're trying to just kind of nip them in the bud and be as much help as we can, as well as email and other means, but we just want to make ourselves available to everyone. Next slide. Now this is a little bit of data. In the next slide, we'll have some data as well, but 4 of the 5 eligible Department of Corrections state facilities have participated in community reentry to date. 46 adults have enrolled in the reentry plan as of the 5th of June. 33 of those people have been released, and 100% of the MCOs have participation in this demonstration. And the big pat on the back really is that we are the second state in the country to participate in this demonstration, and the first was California. So it's a big deal for us here in our little state compared to the big California.
Which facility decided not to participate and why?
The transitional housing unit, mostly we believe because a lot of the people are already Medicaid eligible and they can get their full Medicaid open. So, and they're kind of free, not free. They can go out and look for jobs. They're kind of more, not as restricted in and this is a voluntary, this is not a mandatory thing. They don't have to participate. But as far as we know, and some of the people, there's different levels of transitional housing. There's things called C1, C2. Some of them are already open for Medicaid, so they're eligible, and some are not. So we haven't had any of those that are not participate yet.
Thank you.
But the facilities that did participate are the men's prison, the women's prison, the Berlin facility, and the SPU, Secure Psychiatric Unit. Yep. Did someone else have their hand up? Oh,
Yeah,
oh,
we've
there's-
got two, Isadora and Brooke.
Sure.
Hi, I have a question regarding basically wait times for community mental health. It's actually the slide before this one. So
Okay.
folks are getting 30 days of medication, but my understanding is that to get an intake appointment for community mental health centers could take longer than that. So are they prioritized in some way or expedited? What happens if someone runs out of medication before they have an intake?
So they are considered, thank you for the question. They are considered the priority population as far as our managed care organization as well as our community mental health centers. Sometimes they are able to get them appointments. If they are not able to get appointments, the managed care organization's job and actually priority is to get them an appointment, maybe not with the community mental health center, but with a community-based provider, which they have been doing. If a CMHC is not available, they will get them an appointment with a different provider.
So that they can get medication renewals if
Yes.
needed. Okay.
Yes,
Thank you.
absolutely. Sure. Brooke, did you have a question?
No, you answered it. Thanks.
Okay, sure. So this is a little bit of, I know everyone, I love statistics, so I wanted to give you a few numbers that we have so far. So the number of participants to date is 46. So these 33, as I said, have been released. We do have some people that have joined the program, were excited about it, and something happened, they lost parole, and they're back into suspense. So they're out of the program, but we will they're paused. We call them being paused. So they will have parole at another time, but we will not continue to give them services until they have a new parole date. So those are 13 people and we count them and we track them and we know how many people are coming in and coming out. And we're also starting to track how many people are in the program and how many days they've received the service and things like that. How many people have gone through the entire 45 days. Those are part of all of our outcome reporting that we're going to be doing. But again, we're only a few months in, so everybody wants data. So we're trying to pull as much information as we can. The breakdown, sorry, I didn't spell out the acronyms, but AmeriHealth Caritas has 12 adults. WellSense has 21 adults and New Hampshire Healthy Families has 13 adults. Some may ask why there's no youth. This is an adult program, it's 18 plus. We do have a youth program, which I don't really want to confuse people by, but that's part of the 5121 state plan Consolidated Appropriations Act. And we do have youth and there are 6 youth. I won't confuse people, but we do have 6 youth that are considered reentry eligible to date. So these are a few outcomes and benefits we've heard from inmates as well as case managers and things like that. So this was an inmate. This first one was an inmate that they were hesitant to meet with an insurance company, and they were happy to learn that the MCO care manager was a real person, and that they felt that they were being helped, and they helped them prepare for reentry. So the case managers have reported that the participants feel more confident about post-release plans, and they feel that there is someone there for them in the community and that they feel more directly involved in planning for post-release medical services. So that's really great because we felt before this started, we talked to the DOC staff and they felt like people kind of were walking out feeling that they didn't know what to do and they didn't feel that they'd follow through on their services because they weren't really sure how they were going to get there. There was a lot of issues going on there. So both the Department of Corrections and managed care coordinators have reported that being able to work together, they have a better picture of how to support the individuals during the reentry period. And the case managers are able to build directly from the DOC's previous treatment efforts. So I think just having more people working together is really helpful. And the MCOs have a lot of outside contacts, and they can it just is more coordination. And I think it's really great. So far, it's been going really great. So part of the early case study review, we learned that a participant was able to work with the MCO care manager to secure post-release employment and housing in the community. Another great news. The MCO care managers have also been able to translate pre-release care planning needs into post-release service delivery, assisting with coordinating post-release transportation for individuals because they didn't have access to a car or didn't have their license, or so be it. But we've heard a lot of the post-release continued contact, and they're picking up the phone, they're staying in contact with them, and helping them in any way they can keep their appointments, and it's really great. So several participants have chosen to remain in contact with the MCO following their release. MCOs are continuing to provide holistic reentry support. An MCO delivered a care package to an individual who newly moved into a sober living house. They've also provided, clothing, toothbrushes, anything that they really need. It's a really eye-opening experience from what I've heard for the MCOs as well, not realizing that it's all these things are needed and they're up for the challenge, and it's really great thing to see with coming from them. So next slide. So these are just the future deliverables that we have due to CMS. The evaluation design is due in July. These are things that monitoring protocols we hope we'll be getting from CMS. Midpoint assessment will be due in June, and the interim evaluation report will be due in June of 2028. So it's a little ways out. Again, we're only the second state, so they haven't developed some of these tools yet, but we just list them out. Next slide. The next step is to submit the revised evaluation design and complete, which we're already working on, and to complete the dedicated webpage, which we will have. And I will share with this group once we have it completely up and running, but we are going to have slide decks and any information, frequently asked questions, and some statistics and other information that we think might be helpful to this group and others who want to learn more about community reentry. And any questions?
John?
I'm sorry, did you say John?
Yes, sorry, yes.
Oh, okay. I'm used to hearing Jonathan, so apologize, I was a little stuttery there. My question is just in terms of the overall evaluation of the project, is there an expectation in terms of, the number of people who will actually complete the assessment? Or is that something we're tracking? I know just from our experience here at Manchester, and I don't know what it's been for the other mental health centers, but we've initiated contact with 6 folks out of the, I think, 40 plus that have been identified, and none of them have completed their assessment. One is still incarcerated, and the other 5 others did not complete after being released. So just wondering if that's typical, or if we're sort of looking at that as an indicator of success.
Again, this is all brand new to us, and we're looking for outcome measures to track. I mean, we're always up for looking for things to track and to measure for success, because we want this to be successful. And we have we're still working on the evaluation. So there are several pieces that we want to measure. We just don't, it's new. So there are notes. I'm happy to take a note to have that as one piece that we evaluate, because I think it's important. I think it's an important piece of our success in the state.
And I think, Carolyn, probably what you're saying is it's too early to know if
yes,
it's typical.
Yeah,
because we're all...
it's only been since January, and we really haven't started full implementation since April, because we did a 90-day look back of Medicaid eligibility, and so we've really been trying to hit the ground running, but
And so those might be some early test cases that are
Mhm.
worth connecting on, if you're willing to kind of have a side conversation if you agree, Carolyn.
Yeah, absolutely. Yes.
Sounds good. Thank you.
Thank
Thank you
you.
for raising.
Brooke?
Carolyn and team, I just want to thank you guys for your work on this project, and I think it's really exciting that New Hampshire is the second state to do it. The outcomes for patients and the ability to connect soon to be released individuals. I mean, this is something, as someone who was, I represented people in the criminal justice system 20 years ago when we were begging for this, to know how life-changing it would be. So I'm so incredibly grateful that you guys are spending the time and that the MCOs are collaborating, and of course all the work from the community mental health centers and all of the providers. So thank you so very much for this work. I know it's going to take a while to get the data to be able to demonstrate this, but it is truly going to be life-changing for so many vulnerable people. So thank you very much.
And it does take it. We have to give credit to the inmates as well, because they have to be willing, and they're willing. I mean, they are willing to participate, and they don't want to come back, and they want to get the services they need. So I really give them credit as well, because they are really showing
20
up.
years
They're
ago-
showing up. Yeah.
Right. 20 years ago, I had clients who were from Massachusetts who would say, but when I got released from Mass, I could get Vivitrol. I mean, I don't know if Vivitrol is even a thing anymore, but, they would talk about how it just gave them a runway to be successful and to have new patterns and new social groups, because they had that ability to stay clean for that runway of time when they got released. And so to think that we're preparing them for success, and of course, it's hard work on every single person, the individual participating, the providers, the case managers. I mean, it's a lot of work, but this is something that has been so long overdue. So really appreciate with all the work that you guys are doing that you've taken on this exciting project.
Thank you.
Joan?
Yes, I too echo what Brooke said. This is a wonderful opportunity for our state to shine in this type of intervention. I do have a question on the 1115 waiver on the adult or in the denture for nursing home residents. Is that a separate portion? Is that a separate evaluation?
It's for dentures for members in nursing facilities. That was a piece of legislation that we had to add on to the 1115. That was something that CMS had told us that we needed to do to get it passed. So it's kind of it's not really.
Are they evaluating it in the same way, in these same type of evaluations that you're doing with the CRE?
We do a separate post.
It's separate. Yeah, it's separate. It's a separate post-award form. Yes.
So it's we call this internally sometimes the Christmas tree 1115,
Yes.
because it's one regulatory authority vehicle, but it points to a lot of different programs in our Medicaid program, which can be a little odd to communicate externally because they don't kind of tie together very logically. But basically CMS had directed us to use the existing 1115 authority rather than a separate one when we passed adult dental legislatively, so that we could have them expediently approve it. We already had a post-award forum for the denture component.
And we will again in August. I believe it's August.
Yes. Yeah. So it'll be a separate.
And that's coming from the MCO in the dental insurance space, or?
So yeah, the adult dental program is all in a managed care plan, but it's still the department's responsibility for any, 1115, 1915B, any of our regulatory authorities like that. We do the, approval process with CMS, reporting out on NAC. It'll be from the department. Does that answer your question, Joan?
Yeah, I'm mostly curious as I look at this program and see how it's supported and how it runs. I'm interested, obviously, being a member, the Dental Hygienists Association member, I'm interested in how we get the data for the nursing home residents that are Medicaid, what type of assessments are being done, those types of things. What are the success rates? Which long-term care facilities have joined, that type of thing, because it could be a big deal, although I can assure you elder care is my specialty, and there are many, many more people entering long-term care settings with a number or all of their natural teeth. So this is an issue that I think we need more data on as well, right? To see if we're being successful and if this is, worthwhile endeavor.
Yes.
Does that make sense?
It does. And we could just provide that in a future MAC update, if that sounds like you're curious, for the nursing home facility residents who are eligible for dentures. How many dentures have been, I'm going to use the wrong term, but how many people have received denture services, what facilities, that kind of information is of interest to you. Is that right?
Yes. And, the prevention pieces of it as well. How many remakes do you have to do from lost dentures and things like that? So a lot of data to make sure that the program is being as efficient and beneficial as it can be. Yes.
I think we measure things like repairs and things like that. So what you're kind of talking about, Joan, like repairs and things, repairs.
Well, I'm talking about who is actually doing the denture support post making of the denture.
Okay.
And so that includes the interdisciplinary care, interprofessional care team. And, are the assessments supported well? Who's doing that? In the case of dentures in a congregate living center, they can get lost pretty easily. So, just making sure that you have all those things buttoned up.
Okay.
Yeah, we can bring that to a future meeting, even before the post-award evaluation. And for the 100th time today, I'm grateful that we now have a dental director to assist me in this follow-up. So great timing, Joan. Dr. Hockman, your hand raised. Oh, you're on mute.
I have to do my sign language. Yes, Rob Hockmith from AmeriHealth, and I just wanted to echo the comments about the reentry program. To me, this is a model, a template that could be used in a lot of different places within our society and within our populations. And, normally we kind of work in silos and parallel lines and, interact periodically, but this has just been so synergistic in terms of the case management and the models and the handoffs and the providers and everybody else with pharmacy. And it just works great. And I've been really impressed with it just in the numbers that we've seen. And I just think it's something that we should consider the same type of model in other areas as we move forward, because it really is exciting. And it's nice to see New Hampshire being out front. I mean, even though but it's just nice to be recognized for that. So kudos to everybody who's been involved in it. And I think it's a great, great program. Thank you.
Thank you for your support.
Okay. Shall we move on?
Lisa, Brett, this is Holly. I'm driving, so I don't have the ability to raise my hand.
Hi, Holly.
I apologize. I missed the beginning of the reentry program, but I wanted to know if they think that the cuts to the correction system are going to have any impact at all on the program.
Good question. Go ahead. Sorry.
We are moving forward, and I've had many conversations with the Department of Corrections, and we are all prepared to move this program forward, and we are all dedicated to making this project work. Low staff, whatever it's going to take to make it work, we're going to make it work. So we all are committed to it and very passionate about it. DOC staff, as well as New Hampshire state staff and the managed care organizations, we are all in it. So we don't anticipate anything stopping us. I don't know if you want to add to that
No,
or.
well said.
Okay.
That's great. Thank you. All right. Any other questions before we move on to the standard fare of department updates? All right. Well, let's get right to it with adult dental.
So I'll provide a couple updates on the adult dental program. In April, we had a record number of unique members seen in 1 month through the program at 3,190 unique individuals receiving services. And it looks like we're on track to sustain that in May with over 3,000 unique members. Of course, the claims are not complete for May, so we don't have a final number there. We are bringing an amendment to our dental contract. Probably the next GNC we anticipate. This is our annual rate amendment that we do with our managed care contracts for a 1-year rate update. And the mobile clinic continues to serve members. And this weekend it'll be in let's say it's the 9th. It'll be in Nashua this coming weekend, as well as Raymond, New Hampshire, and following that, a couple dates in Manchester. And please always feel free to reach out for specific information on upcoming mobile van dates. The 1915B, which is another waiver we use to implement the adult dental benefits, is under review with CMS still, and we'll update MAC when we get approval on that for the extension of that authority. And I mentioned at the top of the call, but in case you joined later into our meeting, we do have a dental director joining the department. He's here with us today. Dr. Barry Chang comes to us from California. Topicals, we're just talking about California with reentry. He's served as the clinical director for safety net providers and FQHCs in California, and collaborated with the Medicaid program there in the public health department as a provider fellow. Is there anything else you'd like to add just to introduce yourself, Dr.
Hi
Chang?
everyone, super glad to be here and very excited about this new role that I'm gonna step into. And I've met a lot of really nice people, and I'm absorbing and learning the new role. So it's gonna take me a while to transition, and I'm trying to set up a lot of different meetings, meeting different organizations, and really try to understand the responsibility and duty for the state dental director. So super excited to be here.
And thanks in advance to any of you on the call or are going to be outreach soon or already have to set up some meetings with Dr. Chang. I'm going to hand it next to Scott Beckwith for the DDU update.
Yes, good morning, everyone. So as you could see for the children's cases, we currently have 57 cases pending. With the adult cases, we have 239. With the children's cases, there are 4 that are over 90 days and the adults 11 that are over the 90 days. We are, as you can see, we're right on track where we need to be. We received 179 new applications for the month of May. Our average data processing is approximately 64 days, and we're at a 95% timeliness rate at this point, which is outstanding. And keep in mind that 95%, those include the cases that have unusual circumstances, such as receiving the applications late, incomplete, providers not responding to us timely. So we continue to move forward. I think we're right on track on where we need to be. Does anybody have any questions? Good. Well, thank you.
Great. Thanks, Scott.
On the DHHS roadmap, we provided an update on that drafting process in the last meeting. We're just keeping it on the agenda here, but the final roadmap is not released yet. When it is, we'll kind of bring it back to MAC for an update. I think we're well covered on reentry, unless Carolyn, there's anything else you want to add? Okay. For MCM contract, we are moving forward with an amendment to that that we hope to bring to an upcoming GNC meeting. Don't have any kind of more detail than that. It's our next grade amendment. Since our last meeting, there hasn't been changes really to the home and community-based services spending plan. CMS, as I shared before, had authorized us to extend some programs to the end of calendar year 2025. So we're continuing to do that. And under the waivers section, again, from last month, not anything new on the supportive housing front or 1915J front. I mentioned the 1915B for dental is under review with CMS. Joan, are you raising your hand for one of these items?
No, go ahead.
Oh, okay. And then, Carolyn, we just spent some time talking about the 1115 in her presentation. Medicaid to schools, we are hoping to get to the next GNC with that contract. So if we will get approved for the agenda there, and if we're able to secure approval, we'll be moving forward the next day to implement with that vendor. And then I've kept electronic visit verification on the agenda here since there were some questions in the past. Feel free to reach out if you have specific questions on EVV. And community, in our last meeting too, Kelly, I know she's not on today, had asked about our community health worker state plan amendment, and we had a helpful kind of side conversation stemming out of that. We'll keep it on our radar for an update once it's submitted. It is not submitted as of today. Are there any questions on the department update front? Joan, did you have a question?
No, and not a question. I'm Joan Fitzgerald, representing the New Hampshire Dental Hygienists Association, and I want to welcome Dr. Chang to our great state of New Hampshire. We look forward to learning from you and understanding, how we can support each other. That's a great. We're very happy. Thank you.
Thank you.
And I saw someone ask.
Contact.
Yeah, so I just put his account. Anything else this morning on department updates? Okay.
All right. Do we need to touch base on the HEE 805?
This is Kara. Apologies, my camera's not working today. I don't have anything additional. Kristen was kind enough to reach out to Brian at the end of last week to see if there are any additional updates or comments from the department, and he hasn't been able to respond yet. I don't think I saw Brian on the call. Am I wrong?
I didn't see.
Yeah, we don't have Brian this morning,
Okay.
but we can. We're happy to follow up with
Yeah, I'll follow up again with them.
Okay, yeah, so hopefully by our next meeting, I'll have some updated information. Thank you.
Thanks, Kara. All right, well, am I speaking too soon, or have we kind of come to the end of our agenda today?
I think we have it. Everything else on here is informational. We have the status of a couple rules of interest that we were tracking on the agenda. And then we'll continue to update links here for the department roadmap and then Medicaid budget materials. But Rob, spoke to most of that already.
Yeah. All right. Well, do we have a motion to adjourn?
A motion.
Remember,
So moved.
I second.
it's like Jonathan made the motion and Brooke did the second. All in favor? Aye.
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 Great. Thank you, everybody. Happy to give you about a half hour back. Have
Thank
a good
you.
week.
Yeah. Carolyn and Carrie would be. Sure. Sorry.
Yeah.
No. What'd you say?
Made a motion. Hi, I have
I
some
don't know.
questions. For who? Oh, John's name is yours.
Actually,
Yeah.
okay.
Just right, that's my questions are.
Yeah.
And he's not here.